So let's get into now a description of the phases of normal gait. And we're going to break down the gait cycle into several sub-phases and describe those sub-phases as they would appear in the presence of normal gait. And once we have an understanding of what normal gait looks like, then we can go into a description of what abnormal gait would look like. Now, the cycle of one limb, as it first touches the ground in front of the body, then 2 as it moves behind the body, and then number 3 as it comes back into contact with the ground again, this is known as the gait cycle. Now, to analyze the gait of your injured worker, you begin by looking at the beginning point of the cycle, at initial contact of the foot with the ground. Okay, you then follow the foot as it passes behind the body, and then you follow it forward until it contacts the ground again. This is one complete cycle. Now, this cycle has been broken down into the millisecond by researchers and kinesiologists, and that, of course, would be on that type of analysis would be on the scope of this program, and it's not necessary for the QME examination, however. But some detail about the phases of the gait cycle will make an analysis of normal and abnormal gaits easier and therefore more descriptive in your report writing. And so we're going to go over some of those phases here in this program. Now, the period of time when the foot is in contact with the ground, that's known as the stance phase. When the foot is in contact with the ground, that's known as the stance phase. The stance phase is the weight-bearing portion of the cycle. The stance phase, let me repeat that. The stance phase is the weight-bearing portion of the gait cycle for that foot. And in this case, we're talking about the left foot. Now, the period of time when the left foot is off the ground, that's known as the swing phase. And the swing phase is the non-weight-bearing portion of the cycle for that foot. We're talking here again about the left foot. Now, throughout the gait cycle, 60% of the time is occupied with the stance phase, and 40% of the time is occupied with the swing phase. So 60% of the time is weight-bearing. 40% of the time is non-weight-bearing. And understanding this ratio, 60-40, makes it easy to detect what is described in the AMA guides as, quote, an antalgic limp with a shortened stance phase, unquote. Shortened stance phase. So with a shortened stance phase, or a shortened weight-bearing portion of the phase of gait, the ratio of 60-40 starts to change, and that 60 starts to become a smaller number. In fact, we might see a 50-50 type of ratio between the stance phase and the swing phase, or even less time involved with the weight-bearing phase. And this becomes quite easy to detect when it's present. Now, the stance phase can be further broken down into several sub-phases, including the heel strike phase, the mid-stance phase, and the push-off phase of gait. And because the stance phase occupies the majority of the gait cycle, we're going to take a look at each of these sub-phases in a little bit more detail. Then the swing phase, that comprises 40% of the gait cycle, and we'll get into some description of some normal and abnormal findings of the swing phase of gait as well. Okay, so let's talk about the heel strike phase of gait and findings that we would see in the presence of normal gait at heel strike, and some possible deviations from the normal gait in the presence of pathologic conditions. Focusing all of our attention now on the heel strike phase of gait, and in this example we're again talking about the right foot. Yes, these examples that we're going to go through now discuss normal phases of gait with the right foot. Okay, so at heel strike, this begins with the initial contact of the heel on the ground. And if we focus our observation on the right lower extremity from a lateral view now, we find that in normal heel strike, the head and trunk are vertical. The right arm is slightly posterior to the midline of the body with the elbow slightly extended. And let's just think about this for a minute, doctors. With right heel strike, the right arm is slightly posterior to the midline of the body. So as the right leg comes forward, the right arm goes backwards. Well, as the right arm goes backwards, the left arm is slightly anterior to the midline of the body with the elbow slightly flexed. The right knee is extended, but's not locked, and the ankle is in slight plantar flexion. Now, take a moment to picture this image in your mind. Picture in your mind the image of a person walking normally and focus in on the heel strike phase. Okay? Head and trunk are vertical. The right arm is slightly back of the body. The left arm is slightly forward of the body. The right knee is extended, and the ankle is in slight plantar flexion. And that makes sense. As the heel strikes the ground, the ankle starts to move into slight plantar flexion. Now, in the presence of pathologic conditions, in other words, problems, injuries, trauma, some common observable deviations from the normal pattern that we might see would include a forward shifting of the head and trunk. In other words, the head getting ahead of the midline of the body. We could see that the right knee is locked in extension or hyperextension, or we could see that the knee is flexed and fails to achieve extension. We could see that the foot lands flat on the floor, or even that the toes land first on the floor. The forefoot and toes may slap the ground, and create a mental image picture of each one of these deviations. Picture an injured worker with his body ahead of his head and trunk ahead of the legs. Picture the knee partially flexed and failing to achieve full extension. Picture the toes landing first on the ground and slapping on the ground. I recommend this, visualizing these in your mind, because seeing them first in your mind makes it easier to identify these deviations in the physical world when and if they are present. So go through this exercise in your mind, and therefore the next time you see an injured worker with these deviations, you will have already seen them, and you'll instantly recognize those when they're present. Let's talk about heel strike now from an anterior view. What would it look like if we were to evaluate the injured worker, this time looking at them from the front? Well, again, focusing in on the right lower extremity, at heel strike, we find that the head and trunk are vertically aligned. We see that the arms swing at an equal and symmetric distance from the body. Now you're looking at the injured worker from the front, and he's walking towards you. So the arms should swing at an equal distance from the body. We see that the pelvis lists slightly inferior on the right side, on the weight-bearing side. We see that the right thigh and leg are in vertical alignment with the pelvis, and as the injured worker walks towards us, we see that the plantar surface of the foot is visible approximately 10 feet away from the examinee. As the examinee walks towards us, we start to be able to see the plantar surface of the foot. Now, in the presence of pathologic conditions, in other words, following injury or following trauma, we see some deviations from those normal findings. As the injured worker walks towards us again from an anterior view, we see that the trunk is displaced either to the right or to the left. And more common would be a leaning to the right towards the weight-bearing side. We could see that the right hip is in lateral rotation. We could see that the right hip is in protective abduction in order to broaden the base of support. So we would see that that right hip moves away from, the right hip and leg moves away from the body to contribute to a broader base of support. And we could see, for example, that the plantar surface of the foot is not visible. That would be a sign of limited dorsiflexion of the foot. So take a moment to visualize some of these findings in your mind's eye. Okay, let's take a look now at the mid-stance phase of gait. This is the main weight-bearing portion of the stance phase, is the mid-stance phase of gait. Now at the mid-stance phase of gait, the body's center of gravity is now over the base of support. So looking at the right foot now from the lateral view, with the body's center of gravity over the base of support, we should see that the head and trunk are vertical. Both arms are near the midline of the body with the elbows slightly flexed. Of course, the elbows are going in opposite directions. One's coming forward and one's coming backwards, but they're meeting at the midline as they pass through opposite directions of motion. We see that the knee, the right knee, should be in slight flexion, and the right ankle is in slight dorsiflexion now, as the body moves over the base of support. In the presence of pathologic conditions, we see that the head and trunk now become shifted either forwards or backwards of the hip joint, so that the center of gravity becomes placed either forward or backwards of the base of support. We see that the knee is locked in either extension, hyperextension, or in a position of exaggerated flexion. You might see that the ankle is found to be in exaggerated dorsiflexion. Now, what about from the anterior view? From the anterior view, as the injured worker walks towards you, the head and trunk are vertical, and the arms are at an equal and symmetric distance from the body, and the pelvis possibly could lift slightly now to the left side, and the right hip has a slight lateral rotation. And this is describing a specific type of gait, and I'll reveal that to you here shortly, but for now just picture this in your mind. Now, in the presence of pathologic conditions, the head and trunk tip to the right. Head and trunk tip to the right. The pelvis tilts upward on the left side with the right arm away from the body, or possibly the pelvis has an exaggerated lift to the left side, to the opposite side. Other findings could include an exaggerated outward rotation of the hip and or varus or valgus positions of the foot. And just picture those in your mind, varus or valgus positions of the foot. Okay, so those are some findings in the mid-stance phase of gait. What about in the push-off phase of gait? Okay, so now the foot is moving behind the body. The heel rises from the ground, and the foot is just about getting ready to enter the swing phase of the gait. Well, again, looking at the right foot from the lateral view, in the presence of normal gait, we would see the right arm would be anterior to the midline of the body now, with the elbow partially flexed, and then we would see that the left arm is slightly posterior to the midline of the body, with the elbow extended. Pelvis has an anterior tilt. The right knee is partially flexed. The ankle is in plantar flexion now, and the toes are in extension at the metatarsal phalangeal joints as the body weight gets pushed off by the toes at the metatarsal phalangeal joints. In the presence of problems such as injury or trauma or pathologic conditions, we see that the arms would be an uneven distance from the midline of the body. We would see that both elbows are flexed. The pelvis has an exaggerated anterior tilt. Possibly the knee could be forcibly extended. The ankle plantar flexion may be limited, or the ankle may be in a position of dorsiflexion, and the metatarsal phalangeal joints may be neutral rather than in extension. And that would be common in problems with the foot, for example, pinning of the metatarsal phalangeal joints or of the phalangeal joints following perhaps a crush injury to the toes. And if we look at the injured worker from the posterior view at the push-off phase of gait, in the presence of normal gait, we would see that the arms are at an equal distance from the body. The right elbow is partially flexed, the left elbow is extended, the right hip is slightly laterally rotated, and now the plantar surface of the heel and midfoot are visible, while the forefoot and toes are in contact with the ground or the floor. In the presence of pathologic conditions, we would see, for example, perhaps that the arms could be at an uneven distance from the body. Finally, while the swing phase comprises the lesser portion of the entire gait cycle, approximately 40% of the entire cycle, deviations in swing phase are sometimes even more evident than are deviations found during the stance phase of gait. So let's go over some normal and abnormal findings that we might see in the swing phase of gait. Now again, looking at the right foot from a lateral view, in the presence of normal gait, we would see that the arms are near the midline of the body. The pelvis has a very slight anterior tilt. The right hip joint and right knee joint are both slightly flexed, and the right ankle is in slight dorsiflexion. In the presence of pathologic conditions, you could observe a posterior tilting of the pelvis. You could observe that the right hip and right knee flexion could be exaggerated. You could see that the forefoot is dropped into plantar flexion and that the toes drag on the floor. And take a moment to visualize this in your mind's eye. This is describing the so-called Steppage Gate, or the Equine Gate, found in weakness or dysfunction of the anterior tibialis muscle. And there's many different causes of dysfunction of the anterior tibialis muscle. Now, from the anterior view, and again, just viewing the right lower extremity, normal mid-swing phase would be characterized by having the head and trunk vertical. The arms would be at an equal distance from the body. The pelvis has a very slight list to the right. The right hip is in very slight medial rotation, and the right ankle has slight eversion, the purpose of which is to help the toes to clear the ground. Now, in the presence of pathologic conditions, you might observe that the trunk leans to the left, pelvis is lifted on the right side, the right hip is abducted, and the leg may be circumducted in an arc in order to help the leg clear the ground, and the hip is laterally rotated, and the forefoot is dropped into plantar flexion. Now, these are just some examples of many of the possible different types of deviations in gait, and you've likely observed others. And these examples are just given to help you sharpen your interest in the observation of gait in your injured workers. And I recommend an exercise that you can do to sharpen your awareness of gait, and that is to observe gait in the public, out in the public, whether you're at the supermarket, at the mall, at the post office, anywhere where there's large numbers of people is a good opportunity to observe gait. And I recommend that you make this a regular example, make this a regular process, because like the old saying, what you focus on expands. If you start to focus your attention on gait and gait patterns in the public, your awareness of gait disturbances will expand, and you'll start to notice examples all around you of disturbances in normal gait. Now, because each person's gait pattern is unique and is adapted to their own personal physiology and their own personal somatotype, it's impossible to define one single perfect or even quote-unquote normal gait, but deviations from the normal gait in any person usually stick out like a sore thumb once your awareness becomes tuned in to look for it. And once identified in the setting of the qualified medical evaluation, your task then turns to determining the cause of the gait disturbance. So identifying the gait disturbance is the easy part. Sometimes identifying the actual cause of the gait disturbance is slightly more difficult, and we turn our attention to a determination of the cause of the deviation of gait in our next section.